الآن محاضرة الدكتور صادق الجابري بعنوان Practical Treatment of Heart Failure and Hypertension in Chronic Kidney Disease.
شكرا جزيلا. So, dear gentlemen and ladies, please let me speak about the practical treatment of heart failure and hypertension among CKD patients. الدكتور صلاح طلب مني انه نقدم هذه المحاضرة ما فيها من cooperation and very strong challenging processes اللي بتكون between nephrologist and cardiologist. So the combination of chronic kidney disease with heart failure makes patients management a very great challenge. So we'll speak about the cardiorenal syndrome, which they are broadly defined as disorder of the heart and kidneys, where the acute or chronic dysfunction in one organ may induce acute or chronic dysfunction of the others. It is bidirectional insult. So the patients with heart failure and chronic kidney disease, they have a high mortality rate that reach approximately 15% for every 10 ml per minute reduction in estimated GFR. And the cardiovascular disease, the main cause of death in advanced CKD patients اللي بيوصل تقريبا إلى 68% the main cause of death. مرضى الكورونيك kidney disease, they are not dying because of the uremia, complication of uremia, وإنما complication of it due to cardiovascular risk factors and diseases. And the prevalence of CKD 4 إلى 5 is approximately 30% up to 60% in patients with heart failure. The classification of renal syndrome is well known. I will jump it. We are using the Cockcroft-Gault equation to calculate the estimated GFR. Another equation, it is MDRD, which is very complicated and computerized. The stages of CKD, stage 1 up to 5, depends on the estimated GFR, more 90 up to 120 ml per minute, stage 1, while stage 5 less than 15 ml per minute. The risk factors for cardiac diseases in patients with CKD, we have the traditional known risk factors and untraditional. واحد من أهم untraditional risk factors هو الذي هو decline of the estimated GFR الذي تبدأ من stage number 2 CKD2 less than 60 ml per minute with proteinuria and hypoalbuminemia that leads to the endothelial dysfunction and the well-known cascade that leads to cardiovascular diseases and complications. As we see in Farnham heart study that the coronary artery calcification it increase as GFR decline, and in this section we can see how the medial calcification it raises secondary to the chronic kidney disease due to the calcium phosphorus in metabolism due to the deposition of the phosphorus in the intima of the vessel. The prognosis of this CKD, it is with the CKD with the ischemic heart disease, it can reach up to 15% in transplant patients and up to 40% in stage number 5, stage CKD 5. The pathophysiology of cardiorenal syndrome, it is well known, so I will jump it. How to manage the cardiorenal syndrome or heart failure in CKD patients? The main therapeutic plan we are giving, we are starting with the diuretics. We are using different types of diuretics, starting with loop diuretics, which they are safe in stage 1 up to 5. Thiazide and thiazide-like diuretics, also very effective, but with a limitation. CKD 3, less than CKD 3, we have to avoid. Potassium-sparing diuretics, very effective, and also with the limitation up to CKD 3 with the risk of hyperkalemia. Sometimes we are facing with what called a diuretic resistance, that we are giving a huge amount of diuretics without any benefit due to some conditions like high sodium intake, hypoalbuminemia, and also increase an intra-abdominal cavity pressure. How to treat it? For the treatment of the diuretic resistance, we have to use a combined diuretics, which called sequential diuretic treatment, that we are combining the loop diuretics and also thiazide with hydrochlorothiazide and potassium sparing diuretics, diuretics with potassium sparing diuretics. بيكون very effective and mainly with patients with nephrotic proteinuria and hypoalbuminemia. We are doing also paracentesis to decrease the intra-abdominal pressure. Another options for treatment the heart failure زي ما تكلم الأستاذ الدكتور عدنان الرضي. Beta blockers very safe and very effective. Alpha blockers even. SGLT2 inhibitors very effective. Empagliflozin, dapagliflozins. They have renoprotective and cardioprotective effects. ACE-ARBs and ARNIs, RASI inhibitors and ARNIs, they're very effective. They have also anti-proteinuric effect. They are decreasing. They have also anti-proliferative effect. And we have some recommendations for the RASI inhibitors among CKD patients and heart failure patients. We will start with heart failure with preserved ejection fraction. We will give the RASI inhibitors and the ARNIs, but in a case of increasing a serum creatinine by 30%, we have to stop and to avoid RASI and ARNIs. In a case of heart failure with reduced ejection fraction, we have to give and we have to use and abuse the beneficial effect of the RASI inhibitors and ARNIs, even with increasing a serum creatinine up to 30%. Keep the patient under scope, but in a case of increasing up to 50% of the baseline, try to decrease the dose and tighter the dose. But if there is increasing more than 50%, we have to consider stopping the RASI and the ARNIs. Another options, they are the mineral corticoids. Also, they are very effective, spironolactone and eplerenone. They have anti-proliferative effect, and they have cardio and renoprotective effect. Alivabradine has no significant effect on the kidney function, so they are safe, and we can use them with CKD and heart failure patients. IV iron therapy improves quality of life and relieves symptoms of heart failure. And we have novel pharmacological some agents, the soluble guanylate cyclase stimulators, alverziquat. They are effective when patient with worsening symptoms despite ACE and ARNIs, beta blockers and MRAS. So we can use them, but with the limitation CKD3. When the patient has estimated GFR less than 30, we have to avoid it. The vasodilatory like hydralazine and isosorbate dinitrate, they are safe in any stage of CKD. At last, we have GLB receptor agonists. They are promoting therapeutic options, mainly with options with diabetes, obesity, and also heart failure. They are slowing the CKD progression by reducing albumin, urea, and improving the endothelial dysfunction. They are improving glycemic controls, and they promoting weight loss even. عندما نكون استنفذنا كل إمكانيات الأوبشنز اللي تكلمنا عليها with no benefit, so we have to do for the patient the renal replacement treatment, which is ultrafiltration. We can use peritoneal dialysis or classical hemodialysis الذي هي معنا متوفرة في اليمن intermittent, which will but more better is the continuous method, continuous veno-venous or arteriovenous methods. So in conclusion, the combination of CKD with heart failure makes patient management a great challenge and sometimes is associated with a very poor prognosis and aggressive management of heart failure and CKD 1-3 with present existing therapies such as RASIs, ARNIs, MRAS, and SGLT2 inhibitors leads to slower progression of heart failure and CKD. However, these medications could be limited by hyperkalemia and worsening CKD. شكرا جزيلا. Thank you very much.